Thanks.
Okay. So neuromodulators, just another fancy word of neurotoxins. I know your clients are probably going to call everything Botox, but what's most important for you as the injector is to know the kind of the brand you're working with and what makes it different or unique. So the Dysport is made by Galderma. They're all members of a family, right? So Dysport is a member of the Galderma family. Botox is a member of the Allergan family. Jeuveau is part of the Evolus family. And there are so many neuromodulators out there. There are going to be even more to come. But these are kind of like the three, I don't know, ones that I kind of like focus on, but you should focus on Dysport, okay? So your Dysport vial is going to come in 300 unit vial. It sounds like a lot, but it's a very tiny little glass jar. It's going to be capped, so you can use like a vial capper to take it off. But if you take it off and it spills, you'll probably have to pay for that. But it just makes it a little easier to pull it up. But I'll get into about pulling it up. So reconstitution. The way there's so many different ways you can do it. I'm sure if you get trained by somebody else, they may have a different number. But for the purpose of this kind of like Zoom, I just want you to focus on pulling up 2.5 mLs of bacteriostatic water into your Dysport vial. So that means when you pull it up in the syringe, you're going to go straight to 2.5 and then push it into your Dysport. Mix it around, closed, of course. Now you've got the end product. The active ingredients, you don't have to get super in depth with your clients with it. Just know that they all use pretty much the same, similar kind of protein, the botulinum toxin type A. For me, the difference is the spread. So if you're looking at a patient's face, you're like, well, I don't know which one to use. Let's say they don't have a budget. I would focus more on the way it's a medication, right? So the way the medication works and how much it spreads. So Dysport spreads about the size of a nickel. Botox, Jeuveau spreads to about the size of a dime, maybe a little bit bigger. So keeping that in mind, if you have someone with a super petite face, you may not want to use as many units as you would Dysport, or you may want to spread them out, just taking into account the spread. So again, with Replenish, Dysport is included. I believe, someone correct me if I'm saying this incorrectly. Botox and Jeuveau are not, but I think you can purchase that or get it somehow through the program if your client is hell-bent on it.
Correct.
So I'll go to the next slide. And remember, if you have any questions, just type them in the chat and I'll answer them at the end. So what you'll need for your toxins or your neuromodulators or your Dysport, if you haven't already had a training, I'm sorry, I don't know if everyone has been trained here already. Just kind of how it was during your training, alcohol pads or any type of antiseptic. Your gloves, a marking pen. I use just like a white eyeshadow pencil. It comes off really easily. TB syringes or insulin syringes, a mirror, of course, and some good lighting. And I forgot to add arnica gel. It's totally optional, but it helps. And it also kind of like pro tip, it makes it feel really tight when you're finished doing injections. They're like, oh my God, it's working. You're like, yeah, it's not, but it's working. But that tight feel that they get when they're done and when they have those little mosquito bites on their forehead, it makes them, feel good. So next slide, please. All right, so this I think confuses a lot of people. There are different types of syringes and needles that you can use for neuromodulators. And I'll have pictures on the next slide to show you. So there are Lure Lock syringes where you attach a needle to it. There are TB syringes where, like, if you were to do a TB skin test right under the skin, there are insulin syringes that look like insulin syringes. And then understanding the gauge. Typically for neuromodulators, we use the smaller gauges. So remember, the higher the number, the smaller the hole. So like your 30 or 31 gauge. And the needle length is usually 5/16 of an inch or 8 millimeters, which is very, very tiny because we don't need a super like a half-inch needle. It doesn't need to be that long because in most of our injection points, we're superficial and then deep in the procerus. And on the next slide, I'll show you some examples of most commonly used syringes used for neuromodulators or Dysport. So on the very first one that I'm holding, that's a TB syringe. This one goes to 30 units. The one in the middle is that Laura lock that I was telling you about. And you see it kind of looks like a bottle top, like something attaches to it. That something is your needle. So that means if you purchase this one in the middle, or if you got these syringes, if it didn't come with 30 gauge 8mm needles, you do need to purchase that separately and attach it. I personally don't like these in the middle because I feel like I lose a lot of product in that connect, because you see how there's space between the 0.01 and the top. I feel like I'm losing a good chunk of change right there. But I mean, if that's all you got, you can definitely use it. And then the last one is still a TB syringe. Some may call it an insulin syringe. It's the exact same thing. The only difference is it holds 100 units, right? So don't confuse yourself with the math. It's this exact same thing as picture one. It holds more volume. So if you were pulling, let's just say 30 units, as in, let's just use this for example, because it says 30 units. If you're pulling 30 units on the left, you're going to fill that whole syringe, right? On the right, that very last syringe, if you needed 30, you're literally stopping at 30. It just has more volume, okay? So on the next slide, I'll show you some syringes that you don't want to use. So if you've ever done an IM injection, a flu shot, anything like that, these are the syringes that you use for your reconstitution. You see where it has a 2.5? That's where you would pull up your bacteriostatic water. This is also a Laura lock, which means the needle is attached. So you will attach the needle, pull it up. If this were bacteriostatic, you're doing your reconstitution. This is not the syringe that you want to try to figure out math for when you're actually doing your neuromodulator injections. Big no-no. There's no way you can even count the units. Okay, so next we'll get into the areas for Dysport injections. So I think for this program that you guys are in, you're saying above the nose, so just upper face?
Depends on their
okay. Skill set. Okay, cool. So let's just focus on the basics, right? You guys can get really fancy and advanced as you go down the face and stuff like that. Most typical areas are forehead or frontalis muscle, the glabella, which includes your procerus and the corrugators, right? And then the crow's feet. Now, remember what I said about spread. Dysport spreads pretty big, pretty wide, I should say. So keeping that in mind, someone like a man's face, you would want to really treat him, in a non-conservative way, because most men's face can handle the spread of Dysport, but someone with a super petite face, you want to really be cautious about your markings and how much you're putting in. With the frontalis muscle, there's something called the line of convergence, and all these fancy words just mean is this is the line that we're going to stay above to avoid lid ptosis or dropping of the brow. It's actually technically a drop of the brow. It's not really like the ptosis of the lid. It's really just kind of the dropping of the brow. So the way you find the line of convergence, and I'm so sorry I don't have a slide on this, but I'm going to explain it. So before you even open up your syringe, you are going to have that patient animate. I can't even raise my eyebrows because I am frozen to the gods, but you're going to have them animate. You're going to have them raise their eyebrows up. And when they raise their eyebrows up, you're going to be pushing down. You're going to keep pushing down as they're raising it up until their eyebrow can't go down at the peak anymore. So like, for example, you would start mid-pupillary, and mid-pupillary about 1 millimeter up, you'd put an X right there with your pen that you have in your supply, an X. We don't want to go mid-pupillary because mid-pupillary is definitely going to make them look like this. So after we're mid-pupillary, we do our push test. So we have them raise their brow.
Sorry,
push.
do you want me to stop sharing my screen so they can look at you?
Oh, they can't see me?
They can only see my screen.
Oh, I forgot.
Let me stop sharing real quick.
Dr. A, we can see both.
I can see both.
We can see both.
Yes, we can.
I can see both too.
Okay, my bad, my bad.
Yeah.
Yeah, you just scroll over and then you can
Okay.
see Miss Kathy.
Oh, okay. So we're good. All right. So the push test, right, for your line of convergence. So they raise their eyebrows up, you push. I'm so frozen, sorry. Raise their eyebrows up, push. Mine's about right here. Raise your eyebrows up, push. See how my eyebrows not moving when I'm pushing? Now my eyebrows are relaxed. I'm gonna do it again. It takes a lot of force for me to push this up. If I have a huge canvas, so I have plenty of room to mess up. But if I were gonna draw a line, I'd probably draw my line right here. I draw my line right here. Like, I'm not going to inject below this line because there's a chance that I could drop this brow. And I don't look good with straight brows. Okay. So line of convergence for me is right here. Everything else is going to be above to give me that nice tight look. Okay. And I can, I'll find a way to get this like printed out for you guys just so we can keep this, moving. But yeah, that's what we want to focus on with the forehead, avoiding the lidtosis and keeping things kind of even. When you're dosing your units with Dysport, they go in either 5s or 6s. I think for the purpose of ease, let's just call them 6s. And FDA approved, actually it's FDA approved for the glabellar region only, but we put it everywhere, right? So you can do up to 80 units. I probably don't recommend that, but most people do anywhere from like 20 to 40 in the forehead. And each time you inject superficial in the frontalis, remember, you don't need to be deep. The deeper you are, the more the toxin can run down. We don't want anybody to feel heavy. So your superficial, each injection point ideally would be 6 units. So if I had 1, 2, 3, 4, 5, 6 injection points, each time I go in, I'm pushing in 6 units. So 6 times 6 is 36, right? So that's budgeted 36. Glabella. Glabella has 5 points. Glabella is a little different because in each point you can put 10 to 12 units. But for the sake of this, we're going to say 12 per site. So 12 units in the Proceris. Again, forgive me, I'm frozen. 12 units in the Proceris. Who can put in the chat if the Proceris, that injection, is it superficial or is it deep? Boom, that's right.
Deep.
That's right. Good job, Faith. Good job, Miss Rodriguez. Yep, deep. Good job, Celeste. Yes. So Proceris is deep. So when you go in that injection point with Dysport, you're going to push 12 units. And I'll show you on your syringe where 12 would be pulled up to. Then when you do your corrugators, you can kind of see mine coming back. When you do your corrugators, think about it. I like to think about it like a fish. A fish has a head and a tail. And I like to hit the head and the tail because if I chop off the head, but in this terms, if I hit the head, the tail's still going to be wagging and my brow could do this. Some people may like it. I don't think it's nice on everybody. So if they don't want their brow to look like this, go ahead and hit the tail of that fish, right? So one mirror image, 1, 2, 3, 4, 5 injection points, and each one would have 12 units. So 5 times 12 is 60. I don't know who my human calculators are, but let's start adding this up. 36 plus 60. I'm going to ask you for the total units that I need once we're done, because you guys got to make money from this, right? So we're at 36 and we're at 60. Now for my crow's feet. Oh gosh. Okay, there we go. For crow's feet, you always want to be 1 finger breadth away from your orbital rim. Your orbital rim is literally just the bone of your eye. So being out too far is going to do you no good. Just be right there on the wrinkle. Again, forgive me, I'm talk, so you do not see any wrinkles. So on each side with Dysport, you can do 15 to 30 units. So if we're going with the number 6s, right? Say I had just nice, yummy wrinkles all the way across my crow's feet, right? I'd probably do 3 injection sites, 6, 6, 6. That's 18. And then 6, 6, 6 on this side, 18. So 18 plus 18, 6, 36 units, right? So if you've been paying attention, please tell me how many total units I would need for my face that I just projected. 36 in the frontalis, 60 in the glabella, 18 on the crow's, 18 on the other side of the crow's. So 36 plus 36 plus 60. You can throw it in the chat.
$132.
132. Thank you, Doctor. Yeah. Oh my God. Thank y'all. Yes. Good job. Good job. So I don't know how much you're selling Dysport for, but let's say you're selling it for like, I don't know. What do y'all sell it for? Let's do realistic numbers.
I want to sell it for $5 a unit, but they keep complaining they want to sell it for $4. So it depends.
Okay. So let's say it's $5 a unit times 132, right? So you would say 5 times 132, and you would say, Miss Minnie Mouse, all right, based on what I'm suggesting for you for your beauty treatment plan, the total is going to be around $660. Now I know I'm going a little off, but this is a total game changer. I don't know all your backgrounds, but I'm assuming that probably none of you are in sales. You may have had some sales experience, but going from nursing to this is very different because you start thinking about people's pockets. And this is the industry that if you want to do very well in, you can't really think about people's pockets. You have to treat this as you working within your scope of practice to deliver a medication. I'm pretty sure if that person had like a yeast infection or something, they wouldn't be arguing with their nurse practitioner on what the dose should be. Okay. So you need to be firm and confident in knowing that the dosing that you're suggesting is going to give them the longest results. Think about it when you take your car to get an oil change. I know when I take mine to get my oil change, they give me a full printout of everything that I did not ask for. They're like, I'm just letting you know after like 200 miles, I'm like, that's fine. Just give me my oil change. But yep, we'll move on to the next slide. Perfect. Syringe markings. So I got this from the Inject app. So Dr. A, if you can go to the Inject, just the next slide over. I think it's on all phones, but this is a game changer, because if these numbers just psych you out and for whatever reason you just cannot get the markings on the syringe and it's just confusing you, this makes life so easy. This is the Inject app. It's super simple. It asks you how much is it asks you 3 questions literally. How much is in your vial? 300 units. What kind of syringe are you using? They have a ton of options. You can literally just scroll, pick the syringe you're using. It'll say, how much volume does that syringe have? Remember my pictures, my syringes, I had one that was 0.3 and one that was 1 ml or 100 units. You pick it, voila, you're done. It will literally pull up a picture. So then, sorry, Dr. A, go back to the previous slide. Perfect. It will literally I literally screenshot 3 different syringes. So if you look at the top, 0.3 ml of a BD syringe, this is at a 2.5 reconstitution for a 300 unit vial of Dysport. The one in the middle is a 0.5 BD syringe, and then the last one is a 1 ml BD syringe. So no matter what your syringes look like, they're all the same. The difference is some syringes can carry more. So like, for example, if you're going to treat the glabella area, remember those injection points are they're most likely going to be 12 units. In a rare case, it's going to be 6 units. So if you want to save your product and not waste a lot of syringes, you can either pull it all up in the 1 ml or pull it all up. Let's see, that's 60. So you can pull it all up in the middle syringe, because look, at the 50 unit mark on the syringe, that's 60 units. So what does that mean? That one full syringe of Dysport will cover all 5 points of your glabella. Now, the top of the black plunger, where it says 0 units, at top of that black, that would be pulled all the way down to the 50 unit mark. So when you're injecting the first point, your first point is going to be 6 units, because 60 minus 6 is 54. But you don't think that way. go back. Each big line is 6 units. So if this is 12, you're pushing past 45 to 40. You're going up 10 units. So you're pushing here to 40. Then the next one, you're pushing here to 30. Then the next one, you're pushing here to 20. Then the next one, you're pushing here to 10. And then the next one, you're pushing to 0. Fini. Okay. Oh yeah, see, Sherry's already got this app. Sherry knows what's up. So it's really simple. I'm saying that now. I didn't have the Inject app and I was wasting all kinds of Dysport because it just threw me all the way off. And there are a ton of different titrations. So don't let it confuse you. Get the app, save a life. Okay. Next slide, por favor. All right. So who's this not for? If you're carrying a baby, if you just had one and you're nursing, because nursing mothers just aren't dedicating their breast milk and their bodies to science. If you're allergic to the product, any nerve issues, because remember, this is going in the muscle, so we don't want to create any issues with nerves and any infections at the site. If they just had a cold or maybe they have increased herpes simplex, I always tell them just come when you're healthy. And then the next slide, it's just a picture of consents of an neuromodulator consent, still talking about what to expect and contraindications. And I'm happy to share this with you if you need. I'd also like to say that with Dysport or any neuromodulator, it's not going to be instant. It does take some time, but 2 to 4 weeks is usually the peak, right? 4 weeks for sure is peak. So don't worry. Sometimes it's like trying to kick in and doing really weird and funky things, but just tell them to just leave it alone. I personally don't tell my clients to do any like exercises or anything like that. Just let it do its thing. You don't really have to squint and frown and stuff. The most important thing is to avoid any exercising and don't let anything press in the area. I had one guy, I did his neurotoxins, and then he went on a plane a couple days later and he texted me and was like, is this normal? And I'm like, oh great. And there were circles, huge circles on his forehead. And I was like, do you happen to have headphones? And he was like, yeah, I flipped him up like this. I'm like, oh, he was like, oh shoot. I'm like, yeah, like don't let anything press on it. So don't worry, it goes away, but it's just, he looked like an alien for a little while. So yeah. All right, let's get into the filler while you're all here. So dermal fillers, we all know it's basically just a sugar enzyme that we all have in our bodies called hyaluronic acid. And with Replenish, we use Restylane. So I just broke down the Restylane profiles, the depth of the needle, and what the typical areas that they can be injected and how long they last typically. I forgot Kiss on here, but Kiss is another one that we typically use in the lips. Yeah, so you can use a needle point injection or a cannula. So we'll get into those injection techniques. Next, please. So when you get your, so Restylane comes with 1 syringe in the box. Other filler companies, they usually come in with 2 syringes in a box. So just be mindful of that. But regardless, every syringe you get is going to come with 2 needles that are for that filler specifically. Sherry, how do you know which to use on your client? Are you talking about fillers? Go back up to the dermal filler. Well,
Yes.
if you're wondering, okay. If you're wondering which one to use, let's break it down. So Restylane has a pretty impressive portfolio of fillers. So their OG is the Restylane L, which typically goes under the eyes. But they just got FDA approved last year for a filler called iLight, which is supposed to help brighten darker circles under the eyes, and it can be used, FDA approved for use under the eye. So you would use Restylane L typically, or iLight for under the eyes. if your patient, usually when people have under eye bags, they're like, oh, it feels so hollow. It looks so hollow. I just look tired all the time. They usually need mid-face filler or cheeks. So in that case, you would treat the mid-face first. And with mid-face, you can use lift. Lift goes as a deep injection. So that goes kind of like right above the bone. But contour can be a little more superficial, and it has the express technology, which just means it's supposed to move with you. And is less like contoury, which even though it says the name is contour, but what I mean by it's less contour, it's less for shaping. Like I see lift as a shaping thing, like for sharp jaw lines, chin, midface, like if you really need a strong lift, because lift has a higher G prime. If you hear people talking about G primes, what they're talking about is the viscosity or the elasticity of the filler. So like if you were to take all these fillers and just squirt them out, let's start with lift. If you were to just squirt lift out, it would just stand up like a Hershey kiss. Nothing would, if you left it there to sit overnight, it would still be up like a Hershey kiss. Contour, if you squirted it out, it would stand up like a Hershey kiss, but it would lean just a little, and then it would stay like that. Define and refine, if you squirt it, it would probably fall a little, but it would still maintain, it would stand on business. Okay. Oh, I forgot silk. So silk is lives up to its name. It's silky. If you push it, it would literally go flat like a donut and be wobbly like jello. Silk is good for like really fine lines. And then I'm working backwards. So now I'm on Restylane L and Eyelight. Restylane L and Eyelight. It's a mid to deep injection, which means it does have some sturdiness, but it's soft enough to, if it comes to the surface, it doesn't look lumpy and bumpy. It's okay. Don't expect to know all these fillers is the G prime or where it can go. So in order, lift is the strongest as far as like how it stands up. So you want to be at the deepest layer. You don't want to put lift in lips because you don't want it to possibly like occlude a vessel or any vascularity. You want to stick to things that kind of are mushy when you push it out, or they kind of like they fall a little bit. Yeah, so refine, define can be used in the lips, all around the mouth. I've even used defined in the chin before, like the chin shadows, like here. It's really nice, very pretty. Contour can be used in the cheeks, chin. Lift, I would stick to bone injection, so like mid-face, jawline, things like that. If you get into back of the hands. Yeah, you use Kiss, nice. Okay, so let's get into the different types of injection techniques, which I'm sure you probably went over in your trainings, but I just want to brush over it really quick. Oh, sorry. So back up. No, hold on. So every time you open a filler, a Restylane filler box, it's going to come with the syringe and two needles. Depending on the type of filler it is, the gauge will be different. And you can just read the little sticker. It'll tell you what gauge it is. So like lift, if you remember, because it's thicker, it's going to be like a 27, sometimes a 25 gauge needle. But something that's more silky, like Sherry said, she uses Kiss, that's going to be a smaller needle because we don't want, when we push it, it just kind of like goes everywhere. So you'll see that be usually like a 30 gauge or a 29 gauge. Okay, these are just literally 3 types of injection techniques. And I like this visual because it shows you what it would look like and kind of give you an idea on how to push, right? So when we talk about linear, when we talk about serial puncture or venipuncture, that's when like you're literally just, I call it parking and pushing. You park your needle and you push, you come out. Park, push, come out, park, push. Linear threading is a little different. That's more like when you're in the lips, or if you're using a cannula for the face, where you go in and if you push and pull, that's retrograding, right? If you're pushing as you're going in, that's anterograding, but don't let me confuse you. The point is you're making a line. You always want to keep moving. You never want to just stay in one place and push more than 2 units. Cross-hatching is when that's more common in like nasolabial fold, sometimes the lips, where you kind of create columns and then you go over what you just did in the opposite direction. And then the next visual, I'm going to show you how to mark your client. So marking your client for mid-face filler, this is important for a couple reasons. This is important because you're marking not only for landmarks on where to inject, but also for vascularity and just basic anatomy. So if you look at the picture on the left, they're identified based on their anatomical landmarks. So you can see item 1 is the zygomatic arch, 2 is the nasal base, 3 is the tragus. So when I mark for midface, I start at the ala and I go all the way across to the tragus right there. You don't need a ruler. It doesn't have to be perfect. Just make a straight line. The next line I do is at the corner of the eye, all the way down to it's like the lateral canthus to the end of the mouth. The point of me doing these lines is to make sure that where my lines meet should be at the peak of your patient's cheek. If it's low, you're going to inject too low. If it's too high, they're going to have super high cheekbones that they probably don't want. And remember, it doesn't have to be perfect. It's literally just a guide, a roadmap. So outer ala to the tragus, then lateral canthus to the corner of the mouth. When they smile, it should be right here. And I have a pen. I should do this. And then expert tip, I also draw at the corner of their brow down to tell me where to stop injecting, because you don't want to go all the way up here, look like a cat woman, right? So I love this visual because if you look at the yellow points of the face under like a ultrasound, you can see the areas that they put most of the filler, right? Depending on the result you're trying to achieve, it looks like they use a cannula here, but depending on the results you're trying to achieve will depend on where you're going to put that. So, and remember, these injections are deep, literally on the bone. If you're asking, should I aspirate? Yes, go ahead and aspirate. Never assume. Anatomy, the fear of anatomy is the fear of injection. So go ahead and aspirate. So if you go to the next slide, let's talk some vascularities, right? Most of VOs that happen, when they do happen, are in the infraorbital artery. So infraorbital artery, sometimes you can even palpate it on your patient. It's about 1 centimeter mid-pupillary down. You can go ahead and just X that out. I usually just draw X to remind myself, like, stay away from here. If I have to go under here, I make sure I'm deep, I make sure I'm moving constantly, and I make sure I use a cannula and not the serial or the venipuncture like this. Now, I know some people do go on the bone. It's very risky. I have had a VO before. It is not, you will not sleep. If you do enough injections, you will definitely have one. But what's most important is knowing how to deal with that. And we're going to talk about that, I promise. So if you're ever in a risky area and you're like, oh my God, I don't know if I'm in an area I'm not supposed to be, aspirate, check it. And if you're still not sure, come out. You don't have to inject right there. You can find ways to support that deficit without going into that area. But most times if you're deep, I won't say you're okay, but you're more okay than if you're superficial. Now keep in mind, not to scare you, but also to scare you, the infraorbital artery supplies, let me see who knows. Where are all my like super smart people here? What is the purpose of the infraorbital artery? What is it supplying blood to? Come on, don't show me you wasted Dr. A's money. Yes, okay, Faith. What else? Before the brain, come down a little. Eyeballs. Yes, Faith, thank you. So yes, thank you. Yep, sharing Faith got it right. So your eyes. So this is important to know, because if you inject somebody and you're like, oh my God, it's so good, they look beautiful, and then before their 2-week follow-up, they're texting you like, hey, Faith, I don't know, I've been having this like really bad headache and I've been taking Tylenol, I've been taking all these things, like it's just not going away. And you're like, oh, Schnizzlefoot. Okay, cool. Can you send me a picture? They send you a picture, you see nothing. You don't see bruises, you don't see white spots. Your first thought should be there's probably a little bit of that gel lodged in a vasculature. Say, hey, you keep calm, injector. You tell them, hey, do you mind if when's the earliest you can come in? I just want to take a better look. And they're like, oh, I can, I'm like earlier, better, whatever. They come in. I personally would just flood that area with Hylenex, especially if as you're palpating and you do something right here and they pull away from you, flood it. Filler, it's about to take its course and it's going to get really bad. Flood it with Hylenex, and we'll talk about how to do that and what that is, the dissolver. But it's better to just dissolve and not deal with like blindness down the line or whatever, or necrotic skin, and to just start fresh, right? And you have so many people here that are going to support you and help you and things like that. So yes, infraorbital, you want to stay away from. All right. Let me also say this. You have a, what is this artery? It's an artery that starts kind of like near your mental artery and it comes all the way up through your nose that also supplies oxygenated blood to the brain. This is another area, probably top 2, where we have VOs. And that's when people really, people hate those nasolabial folds, right? But going straight into the nasolabial fold is risky because of the vasculature there. So if you're going to do that, I personally would suggest that you either, well, of course, one, if you're in the nasolabial fold, you're using a cannula. But even before one, that you do a little midface to see if that improves the nasolabial fold first. Facial artery, thank you. Ooh, girl, it is 8 o'clock and my son I can hear him just screaming away. Okay. So yes, facial artery. Another way you can get rid of that nasolabial fold is you can inject what we call the piriform aperture. And it's literally a triangle right on the outside of your nose. If you were to just draw a triangle just like that and go inside the triangle, I usually angle my syringe down because I want to go not with the flow of the blood, but opposite. But I go as close to that nose as I can. And I inject no more than about 2 units. And I tell them, hey, there's a lot of nerves right there. You may feel like numb because of the lidocaine and the filler. You may also feel like a cool sensation. Some people say it feels like water running down, but that helps the nasolabial fold drastically. Okay. I know it's a lot. It's hard to talk all about all of this and anatomy in just little time, but hope this helps. So remember, in cheeks, you can use lift, you can use contour. Wrestling says you can use define, but I would stick to contour and lift. Okay, ready for the next one. Okay, perfect. So we talked about techniques. I think if you went through a training, you probably used a cannula or at least saw it or heard about it. So cannula is super cool. It gives you a nice result, but you just want to really understand where your cannula is. Always know where the top of that cannula is. So if you're like, well, how do I know where to put my cannula? Measure. Where do you want to go first? I always start with the deficits. Let's say they don't have deficits. They're just like, I just want more of a like contoured face, right? So I would start, remember your X, remember your line from the outer ala to the tragus, lateral canthal of the eye, corner of the mouth, where the X meets. Usually in one of those vectors, you have 1, 2, 3, 4 will be perfect for your cannula, depending on which direction you want to go. Most people will fan out this way to give them that like lateral curve, and then a little bit this way to make it a little smoother. Keep in mind, cannulas, they're not like needles where a needle, the hole is at the top. A cannula, the hole is at the side. So knowing where the top of your cannula is every time when you go into the skin, feeling for it, making sure you are where you are before you push the product in is very important. And just remember, keep moving. Cannula is what I use for under the eyes. I don't really like using it in the mid cheeks, but it does look pretty on a lot of people. Okay, slide. Complications of filler. So we briefly talked about that, but this is just a visual.
This is my worst
So
nightmare, by the way.
this is what?
My worst nightmare, by the way.
It's
Yeah.
everybody's. If it's not, then yeah, I don't know. You're very confident, I should say, but you should be afraid. But more importantly, you should know what to do, and you should know the signs early on. So vascular occlusions, right? If they've gotten to this point, that's because it was either a lot of time had progressed, and or it was a lot of filler, right? So who can, and no right or wrong answer, I'm just curious, who can kind of tell me, like, what do you think happened with the lips? How do you think this happened? Could have happened? Was the needle too superficial? Was okay, Genesis superficial. So Celeste says too deep. Below wet to dry border. Yeah, too deep. Exactly. You guys are right. Exactly. And too much filler, very likely. That's a very tight lip. So you're right. I love the way you guys are thinking. Yes. So the lips are the most vascular place that you can put lip filler, right? And I know everybody's eager to throw some lips on everybody, but when you get too deep, you are almost always in a vasculature. And I know there's a lot of arguments on, like, oh, to aspirate or not to aspirate in the lips. As a student, go ahead and aspirate. It takes a little more time, depending on what your injector trainer talks about or how they teach you to inject, but there's nothing wrong with aspirating. Now, do you notice how it's white right there? What do we know about capillary refill? If we press down on it, should it be sluggish or should it be quick to return back to its color? Yes, should be brisk. Very quick, Natalie. Yes, Jenna, quick. Yes, Alejandra, quick. Yes. So filler's kind of funny in the lips because let's say you're doing lips, right? Oh, first of all, let's back up. Always take pictures before, because sometimes I've had patients, they've had scarring and maybe I didn't notice that white part and I finished doing their lips and everything is nice and pink and it's like white, pink. And I'm like, oh my God. So then when I look at the pictures, I'm like, oh, like, honey, your lip do like that. It's been like that before, right? And when I press on it, there was no capillary refill to begin with because of the scar tissue. That's right, Sammy, less than 3 seconds. So if you're injecting and you're like, oh my God, I'm not sure, is this a BO? Don't panic. Press it. Press it. Press it hard. Don't be gentle. Press it hard. Press it and watch. Press it and watch. I've had lips where I was not sure and I was like, let me just throw a little Hylenex in there and it was totally fine. Also, VOs are not always white. Sometimes they look like just a bruise, and this bruise that just continues to grow. That is the key. So the first thing is obvious blanching. That is sluggish, more than 3 seconds. They won't feel any pain or discomfort initially. It happens later on. Number 2 is a bruise that continues to grow, or I always like to add white spots in areas that I didn't inject, like the lady in the middle. The whites, obviously, that's not normal. And 3, sometimes you don't see anything, like I was telling you, for a Midface. They just start complaining about headaches or something else. Yep, I'm going to get into how I inject the Hylenex. But how I typically do it depends on the area. So if it's lips, I will almost always use like a butterfly needle or any type of cannula that I have, and I'm looking for blood return, and then I'm just flooding it. Trying not to fish around, but right now I'm just trying to save some anatomy. And then if it's my work, I know where I inject it. That's why it's always important. Like, I don't know, if you're starting out, maybe if you want to dissolve other people, that's cool. But if it's my work, I know where I injected, so I know how to get in there. And especially if you don't have an ultrasound machine starting out, which most people don't, they're very expensive. So we can go to the next slide so we can talk about dissolving. All right, very tiny little protocol for dissolving, right? So first of all, the dissolvent is called hyaluronidase. Or Hylenex is the brand name. And what it does is basically just eats up the filler, right? And it's pretty instant. And the thicker, remember we talked about those G primes? The higher the G prime, the more Hylenex you're going to use. And Hylenex only works for hyaluronic acid. It's not going to work for calcium-based fillers. Just keep that in mind. This is just a little tiny protocol on how much to use and where to use it and how often to use it if someone comes in. So if you are not seeing, let's say like the lips, someone like that has something like the lips is localized, it doesn't seem like it's spread to the whole face or it's not going up the nose. If they come into your office, I would inject, there's really no count. It's kind of like doing CPR. It's like, well, how many, but it's like, they can't get any deader. Just put like, go. That's how I operate. Like, I don't start thinking about numbers and markings and stuff when I'm injecting. A Hylenex vial comes with 150 units. There's 4 in a box. It's like $350. I start with 1 vial and I pull a 1-to-1 ratio. So for every 1 unit of Hylenex I pull 1 unit of bacteriostatic water or normal saline, which you're going to use for your Dysport anyway. So you should have it on deck. So if I'm pulling, let's say I get a BD syringe and I pop open my Hylenex and I have a 100-unit BD syringe and I pull back 50 of bacteriostatic water and I pull back 50 of Hylenex, I'll probably just pull it until the whole vial is empty and then just start going. And infiltrating it. I have a laser, so I can hit it with the laser too. If you don't have a laser, you can use warm packs. You can get the ones that you can just like squeeze, and shake from the hospital, or if you're a camper, those kinds. I kept those on deck before I got a laser. There are different stages to VOs. So that first stage we talked about, the blanching, right? The pallor, seeing that white, and you just, it's not brisk. It's not getting any capillary refill. That's going to be you want to catch it before then, but you're still in the early phase if you see it like that. Not sure why stage 2. Oh, there's stage 2. Okay. Stage 3 is when you start to see skin breaking down, it start to get crusty. Now, this person clearly missed their 2-week follow-up, most likely. And then it's pretty bad, right? I don't know how maybe they just thought it was normal. I'm not quite sure, but never underestimate a bruise or what a patient is saying about how they feel. At this point, you probably need to, if you hadn't contacted anybody at stage 3, you need to contact somebody. Stage 4, coagulation, it just keeps getting worse and worse. We pray to never get to those phases. If you're at stage 5, that probably means that I don't know, maybe you didn't understand what a VO looked like and just kept thinking it was going to get better, but please don't ever let it get to this stage. The moment someone is expressing to you, like, I think something's wrong, or even if they don't say that, they're just like, I don't know, this bruise keeps getting bigger, or like it's really tight, or it's really painful to touch. I can't even touch my face, or like it hurts to move. Like, take it as it is and let them come in. As you can see, supportive therapy, no suggestions really, because like, what are you supposed to do? Anyway, there are people and I don't know where everybody is, but go ahead and start creating like your support groups and your teams and things like that, because there are injectors that do have like ultrasound machines. There are dermatologists that are happy to help if you ever get in this situation. Dr. A is a great resource for all these things. I know he's terrified of this, but if you ever get into this situation, there's no silly question. Is there a time span to expect their occurrence? Oh yeah, good question of each stage of VO. That's a really good question. I would say the most important time span you need to watch out for is after your injection. Oh, it depends on the area, but in general, within I would say within about a couple days, you will know something, like up to 5 days, you would know something. But it doesn't mean that in a week or 2 weeks or a month that nothing could happen. Because I've also had a girl come to me like a month or 2 after her mid-face filler and was like, "It just when I close my eye, it just hurts. Really, it's really painful." And I was like, 2 months later? I was like, "Okay, tell me about what happened after we injected." She did get married. She went on some huge trip. They did a whole bunch of things in Mexico, like medical tourism. I don't know what they did to her face, but it's possible that the filler could have moved. It's possible that I could have, dislodged a little gel. I was like, "Hey, come on in as soon as you can." So she came in. I said, "Point to me where it hurts." So she started doing the face and she pointed to it. So right where she put her finger, I said, "Okay, now let me put my finger there." So I put my finger there and I was just feeling around and I didn't really feel anything. And I pressed on it. I said, "Does this hurt?" Before I could say, "Does this hurt?" she moved away. I was like, "Perfect." Hit it with a Hylenex and she immediately was like, "Oh, it feels so much better." So she may not have had a true VO, but she could have had some compression from the gel, from the filler laying on a vasculature. So I'm not sure if I answered your question, but the time since these things happen pretty quickly, because think about it, it's blood flow that's occluded. And depending on how much gel is blocking that vasculature will determine how quickly this happens. Um, oh my God, I forgot the other one. Aspirin's gonna be your friend. You can have them take aspirin, baby aspirin, um, or the full 325. Um, but heat is going to be their friend, massage, and Hylenex. So for day one, let's say they come in, you inject the Hylenex. If you're on this protocol where you're doing it every hour up to like 3 hours, um, then I would have them go home because some people can react to Hylenex too. But if you're doing it in the perfect world, like let's say you were taking some exam, I would say like do a TB skin, like a skin test first, make sure they're not allergic. It's important, right? And then you would want to inject. And then you have them come back 24 hours later, reassess, take pictures. If you feel like there's still, if you're doing your blanching test and you feel like the capillary refill is still more than 3 seconds, go ahead and put a little more Hylenex in there. The amount totally depends on, I think it's case by case. Heat, rest, have them come back in a day. As time goes on, you can develop your own protocol. I'm not sure if Replenish has their own protocol or if you guys have your own on how often to see them. Now that I've terrified everybody, we can go to the last slide, the do's and don'ts of filler. If let's say they're not a walk-in and they've planned this way in advance, of course you don't want them to be on blood thinners just so that it can, it's not a bloody show while you're trying to inject, and they don't have any issues healing. And then the day that you inject, I would just have them just relax. We say avoid makeup just because we put a whole bunch of tiny holes in your face. We don't want to increase the risk of infection. If they can, just try not to work out for that day or so. If it's filler, I always tell my filler clients, especially for like molding type places like chin, jawline, mid-face, try to avoid bony prominences. Like I'm always doing this. So when I did my chin filler and was doing this, my chin was like picking up, so I had to like mold it back down. Cheeks, doing this. If they sleep on their hands, I tell them put it under your pillow or lay on your back. For lips, I tell them keep your hands off your waist and off his face. Don't be testing them out because you're gonna be back and I'm gonna have to dissolve and you're having the trout pout. We really want that filler or the gel to stay where it needs to stay for as long as it can. Because remember, like I said, the Hershey kiss, right? It's gonna harden a little bit, but we need it to give it its time. What else? Did I miss anything? I feel like I talked so much. Is there any harm injecting too much? Yes, actually, Jenna. So the short answer is yes. But like I said, it's like doing CPR, right? is there a risk of doing CPR too hard? Yeah, but I'm trying to revive them. I may break a rib, but you're alive. You're alive. So the risk of injecting too much Hylenex is it could eat up the tissue, but not in a way that filler would due to a VO, if that makes sense. Some of the injury may not be intravascular occlusive, but Cynthia, girl, you're gonna do good. That's right. That is right. That compartment syndrome. So what Cynthia said was some of the injury may not be intravascular occlusive, meaning the VO may not be necessarily in the blood, the flow of blood, but compartment syndrome, which means it's like compressing on it, creating this like phantom pain. It's not phantom, it's real, but creating all the illusions of a VO. And that's what happened to my client because I dissolved it. She didn't have, there was no bruise, there was nothing. And it had been 2 months. And I'm pretty sure it had moved from like facials and things like that. So definitely a compartment syndrome. Thank you. Yes. I love it. And that's the end of my presentation. If you have any other questions, please drop them in the chat, or if it's after this, you can ask Dr. A. I'm happy to answer them, or you can just follow me on Instagram. I follow you back and just DM me. If you can go to that first slide, I can, you guys can take a picture of it and the Inject app. My Instagram is Natural Beauty Nurse. Well, I guess Dr. A has these slides now, so thank you, Lucy. I hope it was informative, despite the rough start.
Thank you, Kathy. Okay,
Yeah,
well,
pleasure.
guys, we're gonna try to have these a little bit more often. Kathy, I appreciate this.
Yeah.
If there are no more questions, I have to put my kids to sleep, so. All right, so this is recorded,
Thanks,
so we're
Sarah.
gonna we'll be sending this out. Again, you guys can follow Kathy on Instagram. We're gonna try to work something out with Kathy. I mean, she's already one of our mentors, so you can have her mentor. She's really, really good. But we're gonna try to work something out to where we'll work something else out to where it makes more sense to her too, to have you guys follow her around and stuff like that. If you don't have any more
Yeah,
questions,
I'd be happy to.
actually there are more questions. I see like 10 questions just popped up. Okay, never mind. It's more like thank you. So yeah, we're recording this, so we're gonna send this out again, okay? So thank you guys for coming out again. Oh yeah, Kathy, she's not gonna be in Dallas, but Faith, if you ever come to Houston, Faith is actually a rock star in Dallas, so you know she'd be good to come down.
Nice. But if Dr. A flies me to Dallas, Faith girl, I will be there.
I might
I'm
have to do
happy
that.
to
I might be able to do that. I might be able to do that. All right.
Yeah. I'm
She's a
so
rock.
proud of all y'all. Good luck with everything.
Thank you guys. Thank you. Bye.
Bye.